Hi, friends, good morning. And it's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. And this topic actually is very important, especially in this age, which I present the case in front of you. A little detail about that case and with this topic. Actually, the cervical spondylitic myelopathy is very important topic, and like that a 26-year-old female with history significant for the diabetes, hypertension, and arthritis present with the gait unsteadiness, and that has led to the several falls over the last 12 months. And she further report tingling in the bilateral upper extremity with numbness of her third through the fifth digit and the hand weakness when picking up objects and decreased dexterity. She now is utilizing a walker for ambulation, and examination reveal an overweight female with depressed effect, full 5 over 5 strength throughout the bilateral Hoffman sign, and we can say the we can say here there's a blunted, diffuse sensorium and reflex, and an unsteady gait necessity assistant for the ambulation. The differential diagnosis I must want to present in front of you. Definitely, my provisional diagnosis was cervical spondylotic myelopathy, some kind of, but definitely, if you are other differential diagnosis you want to see, definitely, there the herniated cervical disc, uh, opacification of the posterior longitudinal ligament, cervical spondylitic myelopathy, neoplastic, such as the tumor of the spinal cord canal or the vertebra, pathological fracture, infectious epidural abscess here, and others such as um, I want to tell you here, such as uh, we can say the anotropic lateral sclerosis, or the multiple sclerosis, or hereditary and spastic paraplegia. So here, this is the image I want to show you here. You can appreciate there is a cervical spondylitic myelopathy. In the MRI you can see there are the degenerative changes from anterior and posterior disc disease, and posterior pressure also at C2, C3, C4, and C5, C6, and C6 and C7 vertebra are involved. At tree level you can find, but the most you can appreciate in the axial, there is a significant pressure over the spinal cord and theca. Actually, the image description you can I can appreciate like that, or I can express like that. There, the sagittal and the axial C2 weighted MR images reveal multi-level cervical sclerosis and stenosis at C3, C4, C5, C6, and C6, C7, as I mentioned before, and then the T2 cord signal changes, and the tethering of the cord with the loss of CSF signal at three levels. Further workup, you can do the full set of the labs, INR, PTA, PTT types and screening, and pre-operative ECG, chest X-ray, and the cervical plain films with the dynamic view to evaluate the alignment and the stability, and CT if concern for the ossifoid ligament and considering anterior approach. So the further testing with the EMG may be beneficial to evaluate other causes or myelopathy such as the peripheral neuropathy at ALS. And pathophysiology, actually, myelopathy is due to the compression of the cervical cord caused by the osteophytes and the hypertrophied ligamentum flavum. Cervical subluxation and the herniated disc often superimposed upon the congenital canal stenosis. Spondylosis can cause the repetitive cord trauma from the routine movement and the ischemic injury from the venous stasis and the arterial compromise. So the 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 degeneration of the degeneration of the posterior and the lateral column lead to the sensory changes and upper motor neuron finding typically upon the presentation, which can become permanent over time. And with the time, it can be permanent. And these finding upon presentation is different. The upper motor sign you can appreciate in these patients. Treatment options such as the treatment options in these patients, non-operative, NSAID, lifestyle modification to reduce high-risk activity or rigid cervical bracing may all help reduce further spinal cord compression and particularly in poor surgical candidates. 50% of those treated conservatively and will continue to demonstrate disease progression. Surgical cervical discectomy or corpectomy useful for the predominant anterior compression of 3 or a fewer level, and the laminectomy with or without lateral mass fusion useful for the posterior decompression greater than 3 level involvement. Severe ossified posterior longitudinal ligament, and when anterior approach will not provide more than 12 millimeter and AP canal diameter, even with the preservation of the facet joint, then the laminectomy without lateral mass fusion risk osteophyte progression and progressive kyphotic deformity. And the laminoplasty include such as the French door and a midline enlargement or open door unilaterally technique does not address neck pain. Surgical technique from the posterior, the neurophysiological monitoring is performed. A baseline and the anterior line of the goal mean arterial pressure more than 90 mmHg is placed before prone positioning, and moderate neck flexion aids in opening overlapping posterior lamina. A midline incision is performed with exposure to the spinous process, and intraoperative imaging is used to confirm level. The lamina and the lateral mass of the desired level are exposed, and the extent of the lateral dissection is dependent on need for the fusion. The entire lateral mass is exposed if instrumentation is to be placed. The laminectomy is performed by burying through along the lateral border of the lamina, followed by removal of the interspinous ligament and the precise lifting of the lamina ligamentum flavum in an en bloc fusion. So the careful pursual of the lamina can be performed with the Woodson to ensure adequate nerve root decompression. A kerosene ronger or the drill can be used to open any and persistently stenotic neurofibroma, and once fatty fully decompressed, then hemostasis is obtained and multi-layered wound closure performed. So here, the complication avoidance and the management, actually, the C5 palsies are common due to the short neck and the sensitivity to the traction injuries, and especially special care should be taken when drilling or traction at all these levels, and care should be taken when the elevating the lamina at both the rostral and the caudal ends, simultaneously to minimize levering either end into the cord as the other end is raised, and the poor wound healing from the increased tension after laminoplasty can be reduced by selective debulking of the predominant spinous process. Hyperlordosis can cause posterior migration of the cervical cord in posterior decompression and leading to the neurological decline. So, actually, uh, I think it's enough for this case, and I hope you will like it. If you like it, please subscribe and share. Thank you so much. It's me, Dr. Mohammad Kazafi, and you are watching Dr. Mohammad Kazafi Views.